I'm Dr. Robert Eckel. I'm a professor of medicine at the University of Colorado Anschutz Medical Campus in Aurora, east of Denver. And I have appointments in the Division of Endocrinology, Metabolism, and Diabetes, and in the Division of Cardiology.
I am Christos Mantzoros. I'm a professor of medicine at Harvard Medical School and a division chief there. I'm also the editor-in-chief of the journal Metabolism. I see patients, I do research, and I teach fellows and students.
Hey, Chris, it's good to have you with us here today. And I know your topic for tomorrow's presentation here at the 14th Annual Cardiometabolic Health Congress relates to the concept of fatty liver disease. And increasingly, even the cardiologists are saying that independently non-alcoholic fatty liver disease relates to cardiovascular disease risk independent of its metabolic relationships. So I think in endocrinology, you and I both think of this as a metabolic disorder, and I think you're going to outline that some tomorrow, but kind of reflect on kind of the history of NAFLD and why we might consider this part of the expanded metabolic syndrome.
Exactly. So it's certainly a metabolic disease, and it is certainly very closely associated with the increasing prevalence of obesity in our society. So as we become, as a society, more obese, more and more fat, for those of us who don't have enough storage space in our adipocytes to store the extra fat, the fat goes and is deposited ectopically, where it should not be. So it could be deposited in muscle and cause insulin resistance, in our vasculature and lead to atherosclerosis, or to our liver, where it leads to non-alcoholic fatty liver disease and NASH. So this was under-recognized until recently, and now it's increasingly being recognized as one of the components of the metabolic syndrome.
So the metabolic syndrome I've always defined as insulin resistance, and I think that explains almost every component about completely, almost completely, except maybe hypertension may have some non-insulin resistance components. So as we think of mechanisms for fatty liver disease, the liver is a very insulin-sensitive action. So how do we tie insulin resistance of the liver to the development of non-alcoholic fatty liver disease? What's the mechanism for this development?
Mm-hmm. So our understanding of the mechanisms are evolving, but I hope I'm not oversimplifying by saying that our body recognizes that ectopic fat is deposited in the liver, and it should not be there. So macrophages are going to the liver to remove the fat. Mm-hmm. And this causes inflammation. Ectopic fat does not happen only in liver, happens also in muscle, mm-hmm. and intra-abdominally decreases the levels of an endogenous insulin sensitizer, adiponectin. Okay. So more fat going into the liver, less fat being burned, more inflammation leads to steatohepatitis, and less adiponectin leads to insulin resistance. This, over the years, can lead to efforts of the body to repair the liver. And this leads to collagen formation and fibrosis. And in a small number of people, this will lead to liver failure and the need to have liver transplantations. And now that our hepatology colleagues are very successful in treating hepatitis C, mm-hmm. there is more and more liver failure and need for liver transplantation because of the fat that is deposited to our liver. So this is an emerging public health problem.
But Chris, your comments seem to reflect that it's the fat, excess fat or fatty acids delivered to the liver that relate in the deposition as hepatic triglyceride, rather than de novo lipogenesis or being formed from acyl-CoA that's glucose metabolized down.
Mm-hmm. It is both.
Can you give me an idea what percentage relates to free fatty acid flux to the liver versus de novo lipogenesis?
We think that most of the fat in the liver is because of flux into the liver, less is because of de novo lipogenesis, and this has therapeutic implications.
Well, I think one of the problems for the clinician is to know how to assess fatty liver disease and how advanced it is. So As an endocrinologist, and although my clinic's in cardiology, I see plenty of people that are quite obese or have type 2 diabetes, and I'm concerned about their liver because the transaminases are elevated. But sometimes there can be fairly advanced liver disease without elevation in the transaminases. So how should the clinician approach their patients in terms of the assessment of non-alcoholic fatty liver disease, NASH, and potentially fibrosis and cirrhosis?
Yes, I think that this is a great question, but I think we need to start by realizing that we have to look for it. Most of our colleagues are not looking for fatty liver disease. We are looking for, we are checking the kidneys, we are checking the heart, we're checking the eyes, but most of the time we don't look at the liver. It's not on our radar screen. Okay. And in part, I think this is because we don't have perfect diagnostics and not yet treatments for it. And these are the drivers. But we need to start thinking about the problem. So how do we approach this? If we think about it, we need to, number one, see whether there is fat in the liver. And a simple ultrasound can lead there. We can have simple blood tests, and we are going to discuss during our meetings which these blood tests are. And then if we move down the spectrum from fatty liver disease to fibrosis, one can use FibroScan to look at fibrosis. Right? And you are right that in early stages, non-alcoholic fatty liver disease, some of the liver enzymes, ALT, is going up. But as fibrosis, as the process is evolving and fibrosis develops, ALT goes down and AST may be going up. Platelets may be going down in later stages. Albumin may be going down. So there is a number of tests that are abnormal, but the number one thing to have in mind is there fat in the liver? Number two, if there is fat in the liver, morbidity and mortality goes up. We need to do something about it. What do we need to do? Ultrasound, blood tests, FibroScan. And then, if these are positive, we have to make a referral to our hepatology colleagues. Unfortunately, some people may have to have a biopsy today. And most of my patients don't even want to think about the biopsy.
All right, so that leads me to another question. In fact, two related questions. One is what you're suggesting is that routine screening for fatty liver disease should be part of the visit to a metabolic or cardiometabolic physician. So everyone should have an ultrasound that comes into our clinics. Is that correct?
Certainly, I would say everyone who is obese and has the metabolic manifestations of central obesity should have the blood tests and the ultrasound.
And the prevalence in obese patients, let's define that as a BMI above 30 kilograms per meter squared, is around 60 to 70%, isn't it?
It's 60 to 70%. It's really high. So there is dozens of millions of Americans who have fatty liver today. About 27 million Americans who have NASH, inflammation, and about 4 million, 3.7, 4 million Americans who have fibrosis leading to cirrhosis. And most of them go undiagnosed. In the past, we used to call this cryptogenic.
Cryptogenic. That's a term I used to use when I was an intern or a resident, actually, way back when. So, Chris, to further this thought process here a little bit, in terms of the therapeutic decision-making that we have, we obviously would love to see people lose weight. And we know after a metabolic surgery or bariatric surgery, liver fat reduces substantially. And we certainly know in medically treated people with weight reduction, we can see the liver fat not totally be dismissed, but ultimately reduced in volume. So I guess my question to you is a clinician in the past, when I've seen this clinically, and I send them to GI, and they don't want to biopsy the patient for whatever reason. And as you alluded to before, it's unclear when they biopsy and when they don't. Ultimately, I've used pioglitazone or vitamin E, and there's some data to suggest that. Is that something we can do medically to address this before the FDA finally has a lot of the drugs under development adequately analyzed? Or what are your thoughts?
So you raised a few very important topics. Most of our patients don't want to have a biopsy.
Yes.
So it's a need to develop a diagnostic test with sensitivity and specificity, which would be close to 95, 98%, as close to 100% with biopsy, so that we can replace biopsies.
Wonderful.
And we and others are working on this.
Wonderful. I can't
and
wait.
I think that there we'll hear news in this area. And this can revolutionize things, because at this point, biopsies have a certain percentage of morbidity and mortality. And I don't blame the people, some of the people who don't want to have it. So number two, if we think about it as a metabolic disorder, similar to diabetes or hypertension, we have to start with lifestyle modification, exercise, and efforts to lose weight. If people lose about 10% of their body weight in early stages of NAFLD, this is reversible. The problem is that most of us are not able to lose 10% of our body weight within a short period of time. So number two, what you mentioned, there is medications, PPR gamma agonists, either pioglitazone or more selective agonists that are now being developed that redistribute fat. So there is less fat in the liver, more going into adipose tissue. Adiponectin goes up, and there is more fat burned in the mitochondria. And then, this will probably work, right, in early stages. Later stages, industry will have to develop medications that decrease inflammation or reverse fibrosis. Correct. And this is the challenge.
And there are many companies working on these types of molecules out there, aren't there?
There is 6 clinical trials in phase 3 and 50 in phase 2, if I remember the numbers well. So it's an unmet clinical need. We don't have any medications at this point specifically approved for this condition, but there is hope, statistically, that some of these medications will be approved.
So one of the issues with pioglitazone and the FDA is, I think, since the drug's gone generic, I think the FDA is not in a position to have a company defend this as an indication. But perhaps the pioglitazone data is just more anecdotal for the most part and inadequately documented in publication. What are your thoughts about that approach?
I think we need more trials with PPR gamma agonists in general, non-selective or selective. We need more trials with weight loss medications.
Well, there we go.
We need to prove that they work in NAFLD and NASH. And we need more trials with medications that decrease inflammation and decrease fibrosis. In simple cases, if I could risk a prediction in the future, similar to diabetes or hypertension, we will be starting with lifestyle modification. Always. Simple cases, one medication, like a PPR gamma agonist, may do the job. In more advanced cases, we may have to add medications that decrease inflammation or decrease fibrosis. But this is, right, I'm risking this prediction. We'll see what the future holds.
Anybody can make a prediction, whether it comes true or not. We just have to be patient and wait, right? So often, I think primary care physicians particular, but in addition, I think often metabolic physicians and even cardiologists really don't focus in on the liver disease sufficiently. So your recommendation here is we need more routine screening, and that should draw attention to this. Do you think guidelines can possibly be changed with the information we have now about routine screening? Where are we at? Where are the hepatologists at in this space?
I think guidelines need to change. And as far as the American Association of Clinical Endocrinologists are concerned, I know that there is a team working on new guidelines. I don't know about the ADA or the European Association for the Study of Diabetes, but even if they are not working now, guidelines will follow. I think, and what I teach my students and my fellows is in an obese person or a diabetic, as we look at the eyes, we go down to the heart, we go to the kidneys, we should not ignore the liver. We need to have it in our minds and test for NAFLD.
Well, I think you're focusing on the physical exam, and I might go down a rabbit trail for a second. The exams today are not being done sufficiently. And the other day in the clinic, I ultimately percussed a liver that was, large, and it was tender to deep breathing. So anyway, I think this is an important thing we're omitting.
And with Epic or computerized systems these days, most of the tests that we need for simple screening tests are there. Mm-hmm. So if a primary care doctor or an endocrinologist has this in mind, one can run the formulas and see whether, without adding too many tests, see whether there is higher risk and we need more fibroscans or biopsies or referrals, or whether there is room to wait and follow.
So I'm going to have you be prophetic in one other space, and that's how likely are guidelines going to be updated sufficiently to have liver ultrasounds recommended and ultimately reimbursed? We have third-party payers that have to pay for these too. So what are your thoughts along that line?
I think this, in my opinion, this is a necessary first step. I think that guidelines will be evolving over time. And as soon as or until we develop a new diagnostic test that is very close in terms of prediction with biopsy, right, and inexpensive, we need to rely on ultrasounds, fibroscans, and formulas. But this will be an evolving field over the years.
Well, this has been a good discussion about the importance of non-alcoholic fatty liver disease and evolving liver disease that relate to insulin resistance and the metabolic syndrome. It's really relevant to this meeting's topic, which is a cardiometabolic health congress. And increasingly, we're finding that fatty liver disease is part of the metabolic syndrome, relates to insulin resistance, and needs our attention clinically in terms of assessment and therapeutics to follow. So I want to thank Dr. Chris Mantzoros for being part of this video, and we're hopeful that this is educational for you.